without going on further, I'd like you all to put your hands together to welcome him to the podium.
Thank you very much, Kerry, for your kind words, and thank you all for coming. It's very kind of you, and very grateful that you would come out on such a cold, blustery night to hear me talk about what it's like to be a neurosurgeon. Now, I didn't actually choose the topic, but actually Kerry chose it and chose me and suggested that I might like to give this talk. I said, yeah, sure, no problem. So I didn't think there'd be anyone who'd be interested in me speaking to an empty room, apart from Kerry being here, who's obviously a fan. But but I'm so glad that you all decided to come and hear what I had to say. Maybe some of you have encountered neurosurgery or neurosurgeons in your lifetime, or you want to try and stay right away from neurosurgeons if you can. It's not an area of medicine that you want to get involved in unless you absolutely have to, because obviously we do work that's often fairly difficult, complex work that involves the nervous system, the spine, the peripheral nerves, the brain, and obviously when things go wrong in that area of the body, it can lead to ghastly consequences for the sufferer or their family and their extended family, as it were. But before I start, I might just actually have us contemplate the MH17 tragedy by perhaps just thinking about those poor souls on that aircraft that was shot down so mercilessly by these terrorists. I call them terrorists, these insurgents, whatever you want to call them. We don't know exactly who did it, but it will become clear in time. But let's forget about them. Let's think about the poor victims, and perhaps we should all just spend a few moments in silence to think about them, and also to offer support to those in the audience who have been affected more directly by this horrific event, by dint of knowing someone involved, knowing a family involved, by being from a country that has lost people tragically, like Holland, for instance. We know that there's one in the audience already. Clearly, Australians have lost precious citizens of our country, but we know that there are many students here who come from other countries who may have been involved in this tragedy. So let's think about everyone who might have been involved, particularly those poor souls on the plane who've lost their lives so unnecessarily and tragically, and their families who now have to deal with the consequences. Let's just bend our heads down in silence for a few minutes to think about them. Thank you for that. Even those brief moments of contemplation can mean a lot, and perhaps can lead to thoughts about how we can prevent this sort of awful event from reoccurring. Let us pray that it never occurs again. Anyway, let's move on from those that sad event to what my talk is about tonight. Now, being a neurosurgeon is a tough game. It's a tough game to get to the point of being a neurosurgeon, but it's in fact a distinct privilege and honour to be a surgeon, any type of surgeon, or even a doctor for that matter, because we hold people's lives in our hands, particularly as a neurosurgeon. We can make an enormous difference to someone who could potentially die, and the neurosurgeon can do a procedure which could save their life, or hopefully get them out of a horrendous situation and restore them to good health. Unfortunately, there are many cases that we can't achieve that, and the outcome will not be satisfactory. And that's the nature of neurosurgery. It might be someone with a malignant brain tumour. It might be a child with a malignant brain tumour. I used to be the head of neurosurgery at the Children's Hospital here in Melbourne and had to deal with young children and even babies with malignant brain tumours. You can imagine the horrendous situation that will give rise to the family and the siblings and parents, extended family. It's just awful. So we deal with some very emotionally challenging aspects of medical practice. But we do hold people's lives in our hands. So that's an enormous privilege to have that responsibility and to be able to honestly deal with that with the family and gain their respect and their confidence, and then to carry out a procedure which hopefully will transform the life of that individual and that family. So that's why, you know, people in a way hold neurosurgery in high regard, because it's dealing with these very difficult health issues that can mean the difference between life and death, or being crippled and not being crippled. It can be such that the slightest move in the wrong direction inside the brain can lead to someone being paralysed within a moment. That's the power of the neurosurgeon, to have that decision-making component of their work that will mean if I take a little bit more tumour out, or if I clip the aneurysm and accidentally clip a vessel that shouldn't be clipped along with the aneurysm, that patient has a stroke. They're paralysed for the rest of their life, having been moving their arm and leg on that side before the operation of their face, having normal speech, and then after the operation not being able to speak again, or not being able to move the opposite side of their body. Imagine having the power to in fact commit someone to a lifelong disability or death. That's what neurosurgery is all about. It's a very fine line between getting a good outcome and getting a very bad outcome. So there's a lot at stake. Of course, neurosurgery involves the spine as well, and the peripheral nerves. Things can go very badly wrong in the spine. Things can happen where the person can end up paraplegic or even quadriplegic. It's happened. And it's obviously a disaster for the person and their family. But on the other hand, there are things like spinal cord tumours or traumatic injuries to the spine, where doing the neurosurgery can restore the neural function and bring back someone from paralysis to relatively normal function again. So again, it's a fine balance between getting a bad outcome and getting a good outcome. And that's the skill of neurosurgery, and that's what takes years and years to acquire the judgment to know how far to go with an operation, whether to even do the operation in the first place. It has been said that the best neurosurgeons actually know when not to operate, as opposed to when to operate. And they certainly know how far to go with the operation, what is safe, and when is the boundary crossed until things become unsafe. These are the difficult decisions that the neurosurgeon has to make before the operation, during the operation, and then after the aftermath, dealing with the complications that might arise. So, what does it take to become a neurosurgeon? Who is selected to do neurosurgery? Who is selected to have that degree of responsibility? And the answer is, it's a very long, arduous process. And perhaps I can illustrate it by saying how I became a neurosurgeon, and then perhaps giving you an insight into the current selection process, which is a little bit different to what I went through. So I graduated from this university back in 1976. Oh, and by the way, when I meant to say when Kerry talked about Rotary, that I'm actually a member of Rotary. For those who are Rotarians, you may not know that I'm an honorary member of Chadston East Melbourne Rotary. Why am I not a full member? Because that would involve a weekly attendance at their meetings, and I just can't do that. I just don't have time. But for various reasons, that Rotary Club decided to make me an honorary member of their club, which is in fact the highest honour that Rotary can bestow on a citizen, an honorary membership. So I'm very proud of that. And then I subsequently became a Paul Harris Fellow, and Paul Harris Fellow with Sapphire from another Rotary Club. And I subsequently went on to do other things with Rotary. But one thing I have been involved with Rotary on is the ROMAC. And ROMAC, for those of you who don't know, is the part of Rotary that brings disabled and deformed individuals, particularly facial deformity, from Southeast Asia, where they couldn't possibly get that type of surgery done to repair their deformities, back to Australia to have the work done gratis by surgeons here. And I've done a number of operations, particularly when I was working at the Children's Hospital, to look after particularly the children with these awful deformities that they're either born with or they acquired through injury or whatever. And so Rotary is a fantastic organisation, and puts service before self is the motto, if you like, of Rotary, and I try and live that ideal of service before self in my neurosurgery and my community support. Sorry for that diversion, but it just thought came to me about Rotary, and I thought I should mention Rotary, since we have a lot of Rotarians in the audience. But getting back to my training, I graduated from this university in 1976, became MBBS. They've now done away with MBBS, Bachelor of Medicine, Bachelor of Surgery. They've gone on to a postgraduate course in medicine, which leads to an MD. It's a 4-year postgraduate course with the applicants having done a first degree, usually in biomedical science or science, less so the arts or other fields. We won't go into all the reasons for that, but it seems to have been a great success because it's attracting very high quality undergraduates into the medical course to do the postgraduate course. But I did the 6-year undergraduate course. It was a 6-year course, now a 4-year course. After that, I became an intern at the Royal Melbourne Hospital. And after a while, I didn't decide to do neurosurgery straight away. I decided that I would see what came of things. I became interested in surgery. I had started doing all the different branches of surgery, vascular, orthopedics, plastics, all the different branches, and see which one really attracted me the most. And in fact, it turned out to be neurosurgery after several years. But when I went to my supervisors and said I would like to really do neurosurgery, this is the most interesting area of medicine that I've ever found, they said to me, well, sorry, Jeffrey, but we don't have any places in neurosurgery for you. We are full. We have too many neurosurgeons. We suggest that you go and do general surgery. So I was pretty upset about that. Not only that, but when I was doing general surgery, I can say that when I was in the country doing my first ever rotation in surgery, the consultant at the end of the rotation said, I was still a young neophyte in terms of operative surgery, hadn't really done much. That was my first experience. He said to me at the end of it, I don't think you'll ever be a neurosurgeon. I don't think you'll ever be a surgeon, he said. Forget surgery. Go and do medicine. Go and do internal medicine or something else. So I could have said, well, maybe he's right. I'll give it away. Maybe I don't have the ability to do it. I'll just slink away and do something else. But I didn't say that. I said, this guy is wrong. This surgeon is wrong. He doesn't know what he is talking about. And therefore, I'm going to overcome this obstacle and become a surgeon. So, I continued on. I became a surgeon. But not only that, the neurosurgeon said to me, "You will not do neurosurgery. It is not for you. We don't have a spot for you. Sorry." So I went on and did general surgery. I became a fully qualified general surgeon, which at the time seemed to be not a great thing to do because it's not really what I wanted to do. Having said that, I got a job in London at Whipps Cross Hospital as a senior registrar in surgery, general surgery. Did I take up the job? No, I didn't. Because what happened was they decided in the end, instead of the nepotistic system that they had, where the head of neurosurgery would choose his favourite boy to come and do neurosurgery, boy in inverted commas, because they were all men in those days, there were no women. There was only one female neurosurgeon in the country, that was Elizabeth Lewis. How she got to where she got to, I'll never know, but she did overcome all the obstacles and became a neurosurgeon. There are many more women doing neurosurgery now. It's much more it is a much fairer system. We'll speak more about that for those who want to speak about it later. But I decided that, they decided they were going to have a selection system where they would actually interview people rather than just select their favourite person, which was completely unfair way of doing things, where favouritism prevailed. It was an unjust system. They decided to have an election, an interview system, not election, an interview system, where they would get all the applicants together and individually interview them with an interview panel and decide whether they would do neurosurgery or not. And fortunately they selected me, and I went to train in neurosurgery at St Vincent's Hospital up the road. And I completed my neurosurgical training. By that stage it was now about 11 years postgraduate. So I'd done 6 years of medicine. I did about 5 or 6 years of general surgery, and then I did another 4 or 5 years of neurosurgery. And then I decided that, thanks Kerry, I decided that I would go overseas, because that was the done thing, to go overseas and do fellowship training in particular areas of neurosurgery. Now it so happened that the Cleveland Clinic in Ohio, Cleveland, Ohio, was closely connected with the Royal Melbourne Hospital. Why? Why would Cleveland be connected to the Royal Melbourne? The reason is, it goes back to the Second World War. Because during the Second World War, the Pacific Region Hospital for the US forces was based at the Royal Melbourne Hospital. That's where they set up their major Pacific Basin hospital for the whole of the Pacific region. The most serious cases would come to that hospital. And it actually was set up initially at Melbourne High School, where I also had my education, but then it was moved to the Royal Melbourne Hospital. And so after that time, the doctors in Cleveland set up an ongoing relationship with the Royal Melbourne Hospital, particularly from Case Western Hospital, but also from Cleveland Clinic. And with that, I was accepted as the chief resident in neurological surgery at the Cleveland Clinic. Now, the Cleveland Clinic is rated always in the top 10 US hospitals. It's one of the finest US hospitals, one of the finest hospitals in the world. So I was very privileged to work in that environment. It's a great place to work. Fortunately, the Royal Melbourne also had strong connections with the Radcliffe Infirmary in Oxford. The Radcliffe Infirmary is, in those days, I don't know whether you know Oxford, but that was the original neurosurgery hospital in Oxford, and it was on Woodstock Road, close to the centre of town. They then went on and built the new John Radcliffe Hospital, which became the major teaching hospital for the University of Oxford, which is slightly out in the suburbs, but they've now moved all of the neurosurgery to that hospital. But in those days, the neurosurgery was in the original building from the 18th century, and it was a wonderful place to work. That's where the hospital that first used penicillin clinically in the world was the Radcliffe Infirmary. It's a very historical place to work, and it had a great history and reputation And in fact, the first director of neurosurgery there, Sir Hugh Cairns, was from Adelaide University graduate, who moved to Oxford and became the head of neurosurgery there. One of the first modern neurosurgeons in the world, who became also a colonel in the Second World War, was treating gunshot wounds and military injuries to the head in Oxford, and using penicillin and Septrin to treat those injuries and getting very good outcomes. But interestingly, Sir Hugh Cairns was a pupil of Harvey Cushing. Now, Harvey Cushing is the doyen of all neurosurgeons, the actual father of modern neurosurgery, who came originally from Cleveland, Ohio. In fact, his grave is in Cleveland, and all neurosurgeons, when they go to Cleveland, go and visit his grave. But he worked at Johns Hopkins initially, and then at the Peter Bent Brigham in Boston. And he taught a lot of neurosurgeons who became leaders in the field, including Sir Hugh Cairns. And so there were a number of Australians, very prominent neurosurgeons, who trained under Sir Hugh Cairns. And in fact, one of them was Butch Curtis, who became the director of neurosurgery at the Royal Melbourne Hospital and trained a number of neurosurgeons, including me. So it's interesting to look at the pedigree from Harvey Cushing to Sir Hugh Cairns to Butch Curtis to me, because that's in fact the pedigree. And neurosurgeons do tend to look at pedigrees of who they've trained under, who they've been influenced by. There are different schools of neurosurgery, but the Cushing is really where it started in terms of modern neurosurgery. Cushing achieved extraordinary results in the days even before modern anaesthesia, before there was any diathermy to stop bleeding. Cushing was achieving incredible results in terms of outcomes, and he recorded all of his patient data, the outcomes. He took photographs of most of his patients and their pathology. There was no MR, there was no CT. It was all done by clinical diagnosis and plain X-rays, and amazing outcomes. So we've learned a lot from Harvey Cushing and from Sir Hugh Cairns, and I was very fortunate to work in the place where Sir Hugh Cairns was training the neurosurgeons of yesteryear. So I came back, I became a neurosurgeon at the Royal Melbourne. This was after now 13 years of postgraduate training, and then I started my neurosurgical practice at the Royal Melbourne and at the Children's Hospital. I became interested in paediatric neurosurgery by then. I eventually became the Deputy Director at the Royal Melbourne to Andrew Kay, who's still the Director there. I then became Director of the Children's Hospital when Geoffrey Clark retired. I then was offered the position as Director of Neurosurgery at Monash Medical Centre when it first started back in the early 90s. Having been, when Queen Victoria was closed down and moved over there, I became the Director, and then eventually I came back to lead the neurosurgery at the Alfred Hospital and become the Professor of Neurosurgery. So that's the other aspect of my career. After all those years of training, I decided to become an academic neurosurgeon. Now, most neurosurgeons are not academics. They're practicing neurosurgeons out in private practice who do a lot of neurosurgery day to day. They don't do research. I decided that I wanted to do research and discover new things and stretch the boundaries of neurosurgery, as well as just doing the routine day-to-day practice of neurosurgery. Now, there are some neurosurgeons who only do their private work. They only do spine surgery. That's all they do. But they become very good at it. It's like orthopedic surgeons who only do knee surgery. That's all they do. Just operate on knees every day, day after day, or operate on spines day after day. I didn't really want to do that. I found that was becoming monotonous. The challenge was not there anymore. I decided I needed more of a challenge than that. So I decided to move more into the complex areas of neurosurgery, like cerebrovascular surgery, clipping aneurysms, doing endoscopic neurosurgery, minimally invasive neurosurgery, skull-based neurosurgery, and brain tumour surgery. That's where my specialty has taken me in the practical aspects of neurosurgery. But that's also the most challenging area in terms of the complexity and and what's at stake with the patients that I was speaking about earlier. But as well as that, I've developed a research profile as well and become Professor of Neurosurgery and Surgery at the Monash University. And so, what is my research? Well, it's morphed over the years, but I'll just give you a few examples of what I've been able to achieve on the research front. And one of them is a condition called hypothalamic hamartoma, which is a condition that causes severe epilepsy in children. It's a little tumour that develops in the deep in the brain from the hypothalamus, and it's often only a centimetre or two in size, but it's in a very difficult location. And the results have been very poor from surgery in the past, and these children remain very disabled, often more disabled after the surgery, and some of them even died. Not my surgery, but what had been done previously. And I decided to take a new approach to this type of tumour. It's not a malignant tumour, it's quite benign, it just sits there, but it causes severe epilepsy. So I decided to remove it a different way to everyone else, and I went down between the two halves of the brain and was able to remove it safely and get excellent results in terms of control of the epilepsy and the behavioural disorders. And so I started to get patients from all over the world coming for this operation, children from all over the world. I got them from Mongolia, from Tanzania, from Germany, US, England. I had them from all over, not just me, but the team at the Children's Hospital, including Simon Harvey. I don't take all credit, but I do take credit for the surgery, Simon Harvey being an epilepsy neurologist. We had a very good team there who could look after these children. And so we started getting results that were outside anything that anyone had reported before. And we wrote all of this up, we reported it in the literature. And so other surgeons around the world became interested in this and decided that they would invite me to come and show them what we were doing here, so that I could go and operate on some children over there in America particularly, but also Singapore and England and Israel, and show them what I was doing so they could then take up the technique. And in fact, the Barrow Neurological Institute, which is one of the best neurosurgical centres in the world, with Robert Spetzler, decided that they would open a program to treat children with hypothalamic hamartoma. And they've now operated on probably more than 150 cases. And this is a rare condition. I mean, I operated on about 70 or 80 of them in Melbourne. That was the largest series in the world at the time, but then it was taken over by other surgeons internationally and has become a standard treatment. So that's one thing. But then I became interested in severe brain injury and trying to improve the outcome from severe brain injury, and look at what's happened to Michael. Is it Michael Schumacher? Michael, look at what happened to him. A skiing accident, a severe blow to the head, and now severely disabled. Lucky to even be alive, if you can call it luck, because he's obviously in a terrible state at the moment. I would think. We don't know exactly what he's like, but whatever his state he's in, it's going to be a very slow, tortuous road to recovery. It'll always be an incomplete recovery. So that what I've been trying to do with my research, into not just mine alone, but there's a whole group of people at the Alfred who are particularly interested in brain injury and improving the outcome from these severe injuries. What can we do at an early stage and even at a later stage to improve the outcomes? And we've got a couple of trials going on at the moment. We've had one trial published in the New England Journal where we've taken off the front of the skull and we've done a randomised controlled trial to see whether that would improve the outcome. Unfortunately it didn't, which we reported. But these are the sort of trials that we're doing. And there's another trial at the moment using a drug or a hormone called erythropoietin. Erythropoietin is a hormone that produces red cells. It stimulates the bone marrow, but it also protects nerve cells. So we're using it to test to see whether if we give it early enough, would that improve the outcome. The other thing we're doing at the moment is using hypothermia. So we drop the core temperature of the individual to see if lowering the temperature will protect the brain and improve the outcome. And that's a randomised trial at the moment. So we've got a lot of these very advanced trials going on. And Melbourne, I would say to you, is leading the world. One of the leaders in the world in brain injury treatment. because of all this research that we're doing, finding new ways to treat brain injury. Now, as well as that, I decided to get interested in bionic engineering, and we decided to put a bid in to develop a bionic vision device which would help blind people see again, believe it or not. Now, you may have read about the retinal implant, where people can have an electrical implant put into their back of their eye to help blind people see again. But unfortunately, there are quite a few blind people out there who've got, their eyes are so damaged that they would never be able to have a retinal device. It would never work. So that we decided at Monash to develop a device that would go directly into the brain, directly into the vision part of the brain, right at the back of the brain. And we've been working on this for about 5 years. And we intend to put the first human device in next year. That will be a world first. And I will be putting the device in. I've been helping to design the device and test the device in animals, and not blinded animals, but normal animals, to see how this device is received and how it works, and working very closely with the engineers. As a result of this work, we have decided to set up a whole institute of medical engineering at Monash University, which I'll be leading. It's called the Monash Institute for Medical Engineering. And this will bring the engineers and the doctors close together to develop new medical technologies, new devices, not just for brain, but for all parts of the body. It might be for arthritic joints, it might be for a bad heart, it might be for a sick kidney, whatever it's going to be. It will be a new device that we can build in Australia, which not only will boost Australian research, but it will create new industry, it will create new jobs, it will create new exports for Victoria and Australia, and it's got to be a good thing. So that's what we're doing at Monash University at the moment. And that's what comes from collaborative research, and that's what I do, collaborative research. So I have a lot of different aspects to my career, but I said at the start, and I'll finish soon because time's running away, but one of the things that I said is I've explained to you what the system now is for selection of neurosurgeons. Is it the same as what I went through? No, the answer is it's not. It's become much more, in a way, bureaucratic, but in doing so it's become, in a way, fairer. And what happens is that the candidates have to do a certain number of years post getting their medical degree to be able to get references from the people that they work for, to say this person has the potential to do neurosurgery or whatever other branch of surgery they might want to do. So they get a number of references, having done 3 or 4 postgraduate years. They decide themselves, is neurosurgery for me or not? They have to decide themselves. They really have to show that they are committed to a career in neurosurgery. We have to be assured that we're not going to waste several years of training on them and then they decide this is not really for me, I'm going to change to something else. So we have to be pretty confident of their commitment, and so do they. They have their references, they have their CV. They have an exam. They have an examination to test their basic knowledge in neuroscience, in clinical medicine, in ethics of neurosurgical practice, to show that they've experienced the life of a neurosurgeon and have experience looking after patients with serious problems. We put them into, we then, once they've got through all of that, they will be points scored. And the ones with the highest number of points will then be allowed to be interviewed. This is an Australia-wide interview. There were 80 candidates applying for the neurosurgery positions this year. How many neurosurgeons trainees did they select? About, I think 7 or 8 at the most. 6, someone said 6. I don't know the exact number. I think it was about 6 or 7 out of 80. And these are highly qualified doctors who have already trained for several years in surgery. They want to be surgeons, they want to be a neurosurgeon, but unfortunately the selection is now so competitive that they can't all be selected. We can't train 80 neurosurgeons when we don't need them all. What's going to happen? There's going to be unnecessary surgery if we train them all. They're not all going to have jobs. So the numbers have to be restricted. So we can select very impressive candidates. They have to be not only be impressive academically, but they have to be impressive as people. We have to be assured that they are going to be a compassionate individual who will look after their patients in the way that you, the general public, would expect them to look after people. We don't want arrogant, supercilious, short-tempered, bullying type individuals. We want compassionate, gentle, intelligent, interactive, polite, respectful individuals who will at the same time be able to look after people to the highest of their ability and have the ability to do it. So that's the people that we're selecting. So after they get through that process of the point scoring, they then come to the interview. They sit before a panel of whatever it is, 10 neurosurgeons. I think they also have, I used to do it, I don't do it anymore, I just haven't got time, but they also have non-neurosurgeons and even a member of the general public on that committee. So there is some oversight from outside of neurosurgery to try and select these people. They're put through a number of stations where they'll come across a panel of 2 or 3. They'll be put through a scenario. This patient develops this problem. What would you do about it? How would you have prevented this problem? Mr. X is a bully in your department. Mr. X has a number of complications in this department. What are you going to do to alert the system about this gentleman's complication rate? These sort of quite challenging ethical dilemmas and management dilemmas. We want to test the person out to see how they react to these unforeseen, difficult circumstances. How flexible are they mentally to cope with these situations? We can get a pretty good idea with the references, with the examination, with their CV, with their track record, and with their interview, whether they might be suitable. Now, they put onto the program. If you like, they're on probation for a year or 2. And if they don't come up to the mark, there's a very detailed reporting system for their performance. It's actually now a skills-based program, so they have to reach certain stages of skill acquisition during their training, or they cannot progress to the next stage. They have to be able to do a certain procedure before we let them progress to the next stage. So it's a very controlled system. Maybe you might say too controlled, but there's a lot at stake. We have to produce high-quality candidates to maintain the standards in neurosurgery in this country. And I believe we have some of the best standards in the world because of this very rigorous system of training. As well as that, when you are a neurosurgeon, there's great scrutiny upon your practice, not only from the hospital where you work, because there's a peer review process, your own peers are reviewing your practice. There's also the medical administration are reviewing your practice for re-credentialing and reappointment. There is credentialing of the particular procedures that you're allowed to do. Not everyone can do everything in neurosurgery, so you'll have some specialty bits that you're allowed to do. But as well as that, you're scrutinised from outside the hospital. If you have a death under your hands, that case is reviewed by an external state body that looks at the cause of the death. Was there something untoward, unexpected? Not only that, but we've got APRA looking over us as well, the Health Professional Review Authority, or whatever they're called. They also have oversight. People can complain about an individual doctor, that this doctor is not up to the correct standard, and APRA will look into it. So there's an enormous levels of scrutiny over professional practice in medicine today, but particularly in neurosurgery. It's a very emotionally challenging area of medicine from that point of view, but at the same time, it's a very rewarding part of medicine because of the great rewards that we get from helping people with very serious problems. So hopefully that's given you some insight into what it's like to be a neurosurgeon today. I'm an unusual neurosurgeon because I have a lot of other aspects to my career, and particularly on the research side, but I'm very proud of my achievements. I'm not promoting them to boast or anything. I mean, I'm just telling you that that's what I've done, and that's what I've been able to achieve. But I'm very grateful to have had the opportunity to be able to do what I've done, and I will continue to do it to the best of my ability. Thank you very much.
Go into what he's done in other countries in terms of establishing neurosurgical units, and I was wondering if you could speak to that, please.
So I became very interested in the developing world because I spent 6 months in Papua New Guinea as a general surgery registrar. They sent me up there. That was a standard rotation from the Royal Melbourne, and I became very interested in looking after underprivileged people. And as they're our next door neighbours, as it were, I became particularly interested in PNG. I've also worked in Fiji and the Solomon Islands and other Southeast Asian countries as a civilian, not as a military surgeon. That's a separate part of my life. But I became particularly connected to PNG, and I've been going back there every year for many years to help them develop neurosurgical services there because they didn't have any. There's a country of 7 million people now without a neurosurgeon at the moment, basically. They don't have one CT scanner in Port Moresby for the public patients. They have a private scanner, which, believe it or not, even the public scanner the poor patients have to pay for, and many of them cannot afford it, and they have one private MR scanner. The CT scanner doesn't work a lot of the time. That's just to give you one example of the trouble that they have. But it was important to show them how to do neurosurgery because there are many simple neurosurgical procedures that can be done in the developing world that help people a lot and save many lives. So I've worked with them over many years to help them build that up. And we did train a neurosurgeon there, but unfortunately he's quite ill at the moment and not able to practice. But we're training another one who will become a neurosurgeon there. And I was very proud to receive an OBE last year on the Queen's Birthday Honours because PNG is under the Imperial Award system, and the Governor General of PNG awarded me with an OBE, Officer of the Order of the British Empire, for my 30 years of work in PNG to help build up their neurosurgical services. So that was a great honour, and I obviously didn't work in PNG to receive the honour, but it was a lovely recognition of all of the work that I have done there and will continue to do. Because the PNG people are lovely people, they really are, but they're in a very impoverished environment, and they have a lot of trouble getting support from the government, unfortunately. Even though the government's becoming wealthier and wealthier, the country, due to their mining, it doesn't filter down to the masses, unfortunately. But I'll continue to support them. So that's what happened in PNG.
Thank you for the talk tonight. I'm particularly interested because I work in the Victorian Spinal Cord Service and touched a bit on spinal cord injury. But because I have a social work background, I'm particularly interested to know a little bit more about the neurosurgeon-patient relationship, which you must have some pretty terrified people or something.
Yes. I think that what the patient would like to know is the truth. They want to know what their chances are of getting over the problem that they've got. They want to know what the options are, what the complication risks are. They want to be fully informed. They want to be able to seek other opinions very freely if they're not completely satisfied with the opinion that you've given them. They have to feel that they've been spoken to and not at, and that they have a free interchange of being able to ask questions to the neurosurgeon without feeling belittled in any way. They have to know that they can trust the neurosurgeon. It's that trusting relationship which builds up very rapidly or not. And if it doesn't, then there's usually something wrong with the communication skills of the neurosurgeon. And there's a lot said about communication skills now. The College of Surgeons have training programs in improving communication skills, because that's where things break down. That's where a lot of litigation comes from, is poor communication, breakdowns in communication, where risks have not been explained properly, and the ongoing communication has failed, where the complications occurred, but ongoing support does not follow necessarily. So it's that feeling that the support will be ongoing beyond the operation, that you can trust that surgeon to look after you for the rest of your life, as it were. That's what builds up a good relationship between patient and doctor. But unfortunately, it's difficult to achieve in all cases. Not all surgeons are good communicators. You can have a brilliant operator, but with a shocking bedside manner, who will put people offside. But people still go to that individual because they know that the surgery is going to be of the highest quality. Well, that's the judgment they have to make. But I would like to think that the best surgeons also have the best bedside manners and maintain those very good communication skills and building up those trusting relationships. I aim for that.
Thank you, Dr. Rosenfeld, for a breathtakingly interesting talk. In legal terms, I guess you're up to court judge. My question relates to diseases rather than physical problems with the brain. I'm wondering whether your skills with surgery enable you to assist with evaluating and curing diseases of the brain, such as Alzheimer's or other, which is really not quite surgery, but maybe the two have some interaction.
Yeah, so there are a lot of medical illnesses like Alzheimer's and multiple sclerosis where surgery at the moment doesn't have much of a role. But there are new drug treatments and biological treatments coming online. Let's speak about Alzheimer's specifically, which might preserve nerve cells from dying or prevent all those tangles from building up around the nerve cells and just slowly strangling them, basically. There may be ways of infusing these drugs directly into the brain, or cells into the brain that secrete these protective molecules to preserve what's left of the brain, or actually help the brain repair itself. And I think neurosurgeons will have a role to play in this situation. There may be ways in the future of boosting memory function with electrical implants. It can already be done experimentally. It's been done in primates, non-human primates, to put a little chip in the brain to alter the memory function in the temporal lobe of the primate brain, that non-human primate brain. So there's already glimmerings of electronic devices to improve memory function that are, it's sort of science fiction at the moment. We don't dream of these things, but it's going to happen. There will be surgery for Alzheimer's, but hopefully what there will be is early diagnosis and medical treatments which actually get you to a stage where you don't need the surgery. That's what we hope. The same with multiple sclerosis. It may be that there'll be very early treatments that can, once you start getting multiple sclerosis, that can stop it progressing. Now, whether surgery will have a role in that, in infusing or people have tried to transplant oligodendrocytes into the brain. Oligodendrocytes are the cells that disappear, that get killed off in multiple sclerosis. They're the cells that insulate the nerve fibres. You lose those and the nerve fibres can't transmit their electrical signals in the right order and in the right direction. So if we can restore the oligodendrocytes, we can repair some of the damage of multiple sclerosis. So there are experimental transplants of oligodendrocytes. And you hear of people going overseas and having stem cell implants for multiple sclerosis, but what they're usually getting is injections of those stem cells into the spine. You know, they go to India or Russia. You probably saw that, somebody saw that program on TV the other night about stem cell injections, and the Indian doctor was actually injecting the stem cells at the back of the neck directly into the spinal canal, into the cerebrospinal fluid. So there are these treatments around, but they're unproven. These are unproven treatments at the moment. But look, it may become a treatment of the future to inject some sort of stem cell or precursor cell that can support the injured nervous system and bring it back to health. These are things for the future, but I think that they will have a role in the future. I'd be very optimistic about it, actually.
Professor, may I ask you what propelled you into a totally different area of the army life? I can see that there's a lot to be learned from injuries sustained in war. Is that what it was for you?
Not really. I mean, I joined the Army back in 1984 as a reservist, and I'd already become a surgical senior registrar by then, but I wanted to give something back to my country, Australia. That's why I joined the Army. I wanted to give something back. I wanted to serve my country. And it's said that the highest calling of a citizen is to wear the uniform of the country that you live in. That's the highest calling, to help defend your country against aggressors, shall we say. Now, I'm not one of the fighting men who goes out with rifles and kills people, but I'm one of the supporting individuals who supports the force in terms of giving medical support. So I believe that is a legitimate activity for a citizen to undertake, ethical activity, and I decided to do it. And I haven't regretted that decision at all. That's one of the reasons. There are many other reasons I haven't got time to go into, but that's one of the that's the principal reason.
Professor Rosenfeld, thanks for presentation. I'm just waiting till one day someone to write a biography of your life. But in the meantime, what drives you? What drives Professor Rosenfeld?
To help people, to stretch the boundaries of medical science, to help people, to give something back. Not about me, it's about helping other people. That's what drives me.
Thank you very much for very interesting talk, Professor. Not only you as a registrar, not only I was a student nurse. I was just wondering about, you mentioned hypothermia, wondering about reduced hypothermia in the earth system and what the early feedback and statistics are showing with respect to that. And have you advocated using hypothermia in other settings like such a question?
Yes, so I'm not an expert on the neonatal side anymore, but I know that they are using hypothermia, and even selective hypothermia, where they just cool the brain itself by cooling the head. They put cold coils around the head and just cool the head and try not to cool the whole body. And they find that the outcomes are improved using these techniques. So I believe. There are trials that have shown this. It's not a miracle cure by any means, but it has led to some improvements in outcome for these very fragile little babies. Now, as far as other parts of the body, there has been a lot of work on hypothermia after cardiac arrest, where the heart has stopped, and you can lower the temperature of the body to protect the brain until the heart is restored and the circulation is restored. So that's also been used, and there have been some trials that have shown that to be of great benefit, although one recent trial showed it to be of no benefit, so there's a lot of controversy about it at the moment. It's not used in trauma because a standard multiple trauma, because lowering the temperature actually worsens the outcome for the patient. There's no doubt about that. But when there's an isolated brain injury, then it can be used as a treatment for the brain. Because there's no doubt that experimentally it does protect the brain. How good it is in real life, we don't know yet. There have been a lot of trials. Some of them say yes, some of them say no. So we're doing a trial that's quite unique, because what it involves is that the paramedics will give the hypothermia treatment in the ambulance before the patient arrives at hospital. That's never been done before. This is the first trial in the world that brings the hypothermia soon to the period very soon after the injury. Clearly, when the damage is being done, if you want to reverse the damage, you've got to give the treatment as early as possible. So that study is unique, and when it is, we're about halfway through it at the moment. It will be a world-leading study. There's a similar study at the moment going on in spinal cord injury, which is coming out of the Austin, which I'm also involved in, which involves doing, again, pre-hospital hypothermia for people with acute cervical spinal cord injury. And these are the people that end up paraplegic. If we can give them some movement back, it may not be full movement, but if cooling them down for a few days gives them some movement back and protects their very injured spinal cord, let's do it. But to find out whether it works or not, we have to do the trial. And that's being done. So Australia and Melbourne are leading the world in hypothermia trials right as we speak.
Are you okay to take two more questions?
Yeah, sure.
I just want to know, has any progress been made in motor neuron disease?
It's slow progress. There have been people who are using different neuroprotective drugs again to try and stop those nerve cells dying. But what other people are trying is to actually inject stem cells into the spinal cord to replace the nerve cells that have been lost. They're doing that in experimental animal models, but they're also even trialing it in humans. The results are yet too early to really say whether it's making a difference or not. But clearly these people with motor neuron disease are in desperate trouble because they just slowly deteriorate. They get worse and worse over time and eventually succumb. Unfortunately, there is no cure at the moment, but people are looking at these new forms of treatment to try and improve the outcome and slow the whole process down. I think the most important thing with motor neuron disease is to try and find out what is causing those nerve cells to die. Why do they die? We don't know. Is it a virus? Is it some genetic defect in the cells? Is it some inherited problem? We just don't know. That's the first thing to really work out if you want to cure the thing. But in the meantime, we're working on ways of trying to ameliorate, trying to lessen the impact of the disease.
One last question?
I guess part of the selection process and the training, once someone is accepted, prepares you to deal with a less than successful outcome.
Yeah.
If that happens, is there some mechanism for supporting someone who finds that difficult to deal with?
Very good question. I haven't spoken about the neurosurgeons and the emotional impact on the neurosurgeon themselves. And that is an important aspect of practice, that if you have patients who do badly, when you've done your best, it could have a serious emotional impact on the surgeon and dent their confidence and change the way they're going to practice in the future, and maybe even cause a depression to develop, maybe even cause some mental illness or post-traumatic stress problems, and it can have a major impact on them and their family. It may actually turn them towards alcohol. It may turn them towards illicit drugs to try and cope with the stress of dealing with these very serious problems. Now, there are, through the AMA, medical counselling services freely available. Free meaning absolutely free to the doctor to seek out that support. But probably the best support comes from peers, from colleagues in one's own area of work. Like if I'm at the Alfred and I'm having some bad outcomes, hopefully my colleagues would come to me and say, Jeffrey, are you okay? Are you coping with this okay? Can we do anything to help you? can we come and support you for the next few of this type of operation that you're going to do, to offer that peer support. That's probably the thing that can help the most to buttress the emotional tribulations that the individual will be subject to. It is a serious issue that's become more understood and recognised in the last few years. And when I trained in training in neurosurgery, the emotional side was swept under the carpet, just as PTSD has been swept under the carpet for military personnel for so long. It's now come out into the open. PTSD is spoken about. People are invited to seek help for PTSD in an early stage. Well, the same with medicine and surgery. We're invited to seek peer support for emotional difficulties and nip things in the bud at an early stage to help the person continue on their practice at the level that they were doing it before they suffered these emotional problems, shall we say. But it is being an increasingly recognised problem. There's a lot of thought going into how to help the impaired, in inverted commas, surgeon.